India has a large chunk of babies who are born low birth weight. 30% of the babies born in India are low birth weight, and about one third of them are preterm. Most of these babies are discharged from many NICUs after a lot of interventions and going home. And what is going to be the status of them, what is going to the nutrition of them on follow up is a big debate. Not many people know that post discharge nutrition is the one which has to be a specific entity which has to be looked upon. So many babies who are going home, mothers will ask only whether our baby is going to do well in long term or not. So there are many variables which decide this, how they are going to fare in long term neurodevelopmentally. One of them is degree of prematurity, whether they are IUGR or not, bleed in the brains, or any immaturity in the brain which causes periventricular leukomalacia. And these things are the one which can be adjusted by their clinical settings and by various methods of treatment in NICU. But there are some things like socio-economic status also which may make a say in predicting the neurodevelopmental sequelae. And the one which is more and more neglected is the postnatal nutrition, because it is the nutrition which will decide how the baby is going to fare in long term. So if you see it, the brain development per se, the brain development per se starts antenatally and continues for 2 to 6 years of life very rapidly. And in this first 9 to 12 months is very critical, which is said to be a very critical period in the child neurological status in long term. For this, whatever diet and nutrition what we take in first 9 to 12 months is important even for a preterm baby. So typically a baby who is going home, say 1 kg or 800 grams, at the time of discharge, if you see, because most of the NICUs, they won't give full total parenteral nutrition. Even enteral nutrition will not supply all the calories and protein. So at the time of discharge, most likely they are likely to be compromised growth, and growth status is below comparable term of same gestational age. And linear growth itself doesn't tell the story, because if you see the lengthwise, most of these babies look very long and thin. But it's the bone, brain and lean body mass, these are the one which have to be seen. And even at 40 weeks post-conceptional age, if you take a preterm baby, special needs exist. Means they lived on their debt. Means whatever they had in utero, they have spent it to come out through the catabolic phase of prematurity and infection and the growth. So they have a high nutrient requirement because of accumulated protein and energy deficits and decreased bone mineralization and uncertain vitamin A stores and possible antioxidant depletion, because all diseases like HMD or BPD or NEC or IC bleed, all these are basically mediated by free radicals of oxygen. So their antioxidant defenses are used up, and they have possible deficiencies of zinc and other micronutrients which we have to know at the time we are discharging the babies. So now to summarize, every baby, though whether it has in utero growth retardation or not, all preterms have an ex utero, extrauterine growth retardation because of early growth delay. And along with that, there is lack of catch-up growth. Means at the time of discharge itself, they are in deficit. Along with that, after discharge, they may not grow well. So this is the most frequent cause of morbidity seen in VLBW babies. And when we speak to our colleagues in neonatology, they say 20 to 40% of babies who are discharged from NICU will have these problems and get readmitted for this reason again. And this is the underlying cause behind poor growth. So this may have long-term consequences on the neurodevelopmental outcome. So post-discharge nutrition is one entity which has come into limelight recently, and it's coming up in India also. So best practices on post-discharge nutrition, they continue to be evolved. But before we go further, we need to answer some key questions. One is whether these VLBW babies have any specific nutritional requirement in post-discharge period, and whether this is critical for later health and development or not. So if you see this graph, there are two phases. If a preterm baby is born, early means as soon as a baby is born and brought to nursery, there is a phase of early nutrition, wherein we recommend TPN on day 1, total parenteral nutrition, start feed early, see that they won't go into deficit and they maintain their weight. Second stage, they have a growth which are in NICU, which is a primary grower phase. So here the growth is very rapid. During this time we give feed and TPN, and as early as possible we will go on to full feed. But if you see later in the right side last part of curve, we can see a steep curve which is the post-discharge nutrition, during which all the nutrient requirements increase very rapidly. So this is the phase what we have to match, and they are not with us. Most of the time these post-discharge babies are with the mother in their homes. We can't assess them every day and can't give them guidance on what to give. So for this we need to have specific post-discharge instructions on how to do and how to go about it. So what are the nutritional risks what these post-discharge babies have? So they have a nearly 25 gram per kg of protein deficit, and we need to give up to 3.2 gram per kg protein daily. Say if you take a normal term baby which has a requirement of 1 gram per kg, if you see roughly, this is approximately 3 times more, 3 to 4 times in between the higher normal requirement. And if you take energy, in addition to their growth of the term baby for that day, there is a 1000 kilocalories per kg deficit is there in the energy as well. So roughly they need another 110 calories per kg per day. This, if they are living in an environment which is very cold, that cold stress also may increase their energy deficit to a major extent. In addition to both of protein and energy, they also need iron for growth, and they need approximately 2.25 milligram per day iron. So if the baby is needing only it for growth, it's only 2 mg per kg. But if the baby also has iron deficiency, you need up to 6 milligram per kg. So there is issue of wide iron status at discharge, which is the focus of many researchers now. How much baby has got iron at the time of discharge and how it is finding. And recent data says even this 2 gram per kg or 2.24 grams is much low. They say up to 4 to 6 grams is the one which is the target. But why we need so much of protein? Why we say normal compared to normal 1 gram per kg per day, we are telling roughly 3.2 or 3 or 4 gram per kg per day? Because all this protein is required for DNA and RNA synthesis and maintenance, for neurotransmitter production, for synaptic efficiency, for growth factor synthesis, and for structural factors in the brain like neurite extensions or synapse formation. For all these, brain needs lot of protein, and unless this is there, they are going to suffer sequelae in future. And why brain needs so much fat? For cell membrane, for synapse formation, for melanin, brain needs fat. So fat and protein are okay, but iron is very critical, because many iron is a critical nutrient for a developing human, and they say 0 to 2 years is the window period where if you don't supply iron in enough quantity, they may have sequelae, neurological sequelae and developmental sequelae and even behavioral sequelae in future. So why iron is important? Because it is a part of so many cellular processes, particularly delta 9 desaturase, glial cytochromes. They control the oligodendrocyte production of myelin. So whatever myelination happen which is responsible for development of the child, the control of that myelination is through oligodendrocytes, which is controlled by the enzyme which contains iron. And these cytochromes also mediate oxidative phosphorylation and determine neuronal and glial energy status. So whatever brain hypoxia comes, that is controlled by iron. And the tyrosine hydroxylase, which is there in all transmitters, it also needs iron. So because of this, all these enzymes for basic myelination, for energy use, as well as for neurotransmitter synthesis, iron is very much required. So there are many people who looked at whether all this is true, because to speak in theory it's very easy, but people have looked at. Alan Lucas from UK way back in 92 published a paper in which he has seen that preterms who are less than 34 weeks, they are randomized to standard term formula and follow on preterm formula. What he told was, compared with term formula, preterm formula whoever have taken, they have higher rate of head growth between 2 to 6 months. But this growth was not different at 9 months. So with this, many people subsequently looked upon this part of newborn growth, wherein there is another study from Cook which has published in Pediatric Research in 98, wherein they have seen between a preterm formula and specific follow-up formulas. So what they have showed is male babies had higher head circumference than other babies, but in female there was not much of growth. But most of these papers have not gone much details compared to what we spoke. This has not shown much results, but people have known, particularly whatever calcium accumulation and whatever accumulation for somatic and brain growth happens in first year of life. So in VLBW babies who have caught up by 8 months, they have failure to catch up by 8 months. It means lower developmental scores may be there, small head circumference may be there, and they may have higher rate of neurosensory impairment. This has been well known in a study by Hack et al. From obstetrics. So why all this is important? Because we know about Barker's hypothesis, that there is a principle of long-term programming. Say whatever you grow in utero and whatever you grow in first 2 years, that is the one which is going to decide how you perform in future. So there is something called long-term programming hypothesis, and people also realize that there is a window period in first 2 years of life which may be causing consequences of early undernutrition. And not only this, we are speaking only about undernutrition, but if somebody is growing too rapidly, if a UGR baby is there, given inappropriate supplementation, if the baby grows up too much fast, that also may cause problems in long term. So even problems of rapid growth are also seen. So for this, we need to make sure that what we are giving to these preterm infants in post-discharge state should be ideally matching and should give their best to them, to their potential. So what is possible? What we can do? The idea is human milk is the best. Human milk is the gold standard. So it's the preferred feeding for the ELBW and VLBW babies because of immunological value, antimicrobial components which no other formula can give, because of the nutritional values, and it contains all hormones and enzymes. And once growth is established, if the baby is growing well, nutritional needs of preterm babies exceed the content of human milk. Means for up to 1.5 months, the preterm milk contains higher protein, but after a few months or few weeks, the contents will drop. So the nutrient requirements of the preterm baby increases. So that's why we need to supplement protein, calcium, phosphate, magnesium, sodium, zinc and other vitamins. So predominantly, if a baby is unable to get mother milk to desired extent, then we need a formula for preterms which should be an enriched formula. So it should contain predominantly more protein and more energy. It should also contain extra calcium, phosphorus and zinc, and it should also contain additional vitamins and trace elements. The goal is to increase proportionate growth. Means it's not to increase the weight of the baby as such, it is to cause good amount of proportionate growth through proper calcium deposition, proper bone growth and increase lean body mass. So if we see the protein comparison for the post-discharge transition, you can see here in this slide from a book of Sang et al., who has written Nutrition on Preterm Infant in 2005. You can see the term breast milk contains a protein which is nearly 1.1. Term formula contains a protein which is nearly around 2, whereas nutrient enriched formulas will contain up to 2.5 to 3, whereas a high protein formula post discharge nutrition will contain protein up to 2.5 to 3. So if you see term to preterm, preterm to post discharge formulas, the protein content gradually increases, and we need higher protein to compensate for the deficit what preterm babies have. So people have seen, this is a study by Bishop who has published a data on how nutrient enriched formulas, if they are given properly, increase the bone mineral content in 9 months post conceptional age. What they have shown is, they have shown significant difference between people who have been given term formula and nutrient enriched formulas. The bone mineral content is very much better if you are given a nutrient enriched formula for preterm baby. So there is another study which is much more recent, published by Carver. What they have done is, they have taken babies of less than 1.85 kg. Then they have randomized them into two groups. One group receiving term formula containing 20 calories per ounce, other nutrient enriched formula 22 calories per ounce. Then they have fed to 12 months. Up to 12 months age they have given, and they are stratified by birth weight and gender. So what they have shown in this study is, babies who have been given nutrient enriched formulas, they have gained more weight and they are longer by 3 months. And even at 1 month, 2 months and 6 months and 12 months also, they had better growth, better height and better head circumference also. So particularly those babies who are less than 1.25 kg babies, and in this study male babies, they showed that is a particular benefit. So now we know the deficits, we have seen some study. Now what to do now? What to do? What is the take home message, what we can give? Say one strategy does not fit all. We can't say generalize that every baby should get this or every baby should get that. And every baby we have to monitor during their discharge about their growth, their head circumference and length. And we should not sit back and accept and resign on day one telling that poor growth is inevitable. We have to do a proactive approach in which we have to tell that this baby has to grow in the normal in utero growth. Whatever baby is growing in utero, that curve baby has to reach. And if the baby is breastfed completely, you should have individual strategies. Like if the baby is taking express breast milk, you say that directly on breastfeeding, they can go as soon as they demonstrate good milk output and good growth. And we have to always communicate with the primary caregivers. Many times the neonatologists may not be taking the follow-up. Sometimes they may refer to the pediatricians. We have to be in touch with them, telling that this baby has to grow here and this is the growth chart of this baby. You have to plot on this. If the baby is dropping down on the growth curves, you have to come back. If baby is increasing in growth, then you have to tell us, because baby is prone for problems if it increases rapidly. So basically we have to maintain a nutrient enriched strategies for proportional growth. So for breastfed babies, what to do? Breastfed babies, we need to monitor growth more frequently and individual feeding strategies to maximize the growth. To tell in brief, say if I am giving tube feed, after every few tube feeds, I want to change on to spoon feed. After spoon feed, once they go home, all people will ask whether to try direct breastfeeds. If they try direct breastfeed and if the baby sleeps in between, you don't know how much feed baby has got. So that's why we have to take them that how to ensure adequacy of feed when taking direct breastfeed also has to be taught of in post-discharge nutrition. And if the baby is a formula fed baby in first year, we have to make sure that they make in proper dilution, proper concentration and proper formula is given. Not all babies may need post-discharge formula. If somebody is not thriving well, if their preterm formula itself is not enough to meet the growth needs of that particular baby, they need proper post-discharge formula. So post-discharge breastfed babies, these are the instructions what we can take home. Like we have to give iron supplement from the time of discharge, though some books say at least 4 weeks you have to wait, and continued use of fortifiers of calcium, phosphorus, zinc, vitamin D and protein supplements like human milk fortifiers specifically with idea of supplementing these elements can be used. A multivitamin supplement also can be used, and as the baby is weaned off, say after 6 months, most of the time the breast milk output may come down. Then you have to wean off to a iron fortified post-discharge formula with appropriate contents of DHA, and any deficiencies you have to monitor and treat, and introduce solids only after 6 months of age, and you have to monitor growth. So this is all for breastfed babies. So use fortifier, use supplements, and after 6 months if breast milk is not enough, consider use of appropriate formula, and weaning foods after 6 months of age and monitor growth well. If a baby is completely breast milk fed, say what we can do is there are various options, like sometimes you can give a preterm milk, sometimes you can give human milk fortified to breast milk until they are 9 months old. So to fortify is to see that if baby is going to gain weight well with breastfeeding, this fortification you can continue up to 9 months also. And sometimes if milk is not enough, they can alternate breastfeeding with a preterm milk. And all these babies you have to continue iron at around 4 mg per kg per day. The range is you can go up to 6 mg per kg per day as well. And preterm infants after discharge, always tell them to come back, educate them, tell them that this is the issue what you have to recognize. So how much weight gain has to be expected in next visit, how much is expected you have to tell before you send them home, that every week I am expecting a weight gain of say 30 grams, next week I am expecting weight gain of 10 grams per day, like that. And monitor anthropometry and office visit. Don't just auscultate and see clinically and send. Always measure head circumference, length and weight and maintain on a correct growth chart, not on the usual growth charts what we see. And always provide nutritional counseling and order lab test only when required. If you do repeated lab testing, they won't come back telling that you will prick the baby unnecessarily. So that's why only when you feel it's inevitable, then only order blood test, simple blood tests like hemoglobin estimation. So if a baby is not breastfed, what are the options what we have? Say in advanced countries, in India right now we don't have access to specific post-discharge formulas because none are available as of now. But if you see in the West, they have a preterm formula, they have a preterm post-discharge formula, and they have term cow milk based formulas as well. But if you see the composition, the energy is very much different in them. So the post-discharge formulas typically lie between a preterm formula to term formula. The composition lies in between, in the middle. You can see in this table that most of the contents like energy, protein, calcium, phosphorus and vitamins, they lie in the middle. So post-discharge formula composition is between preterm formula to term formula. And post-discharge formula fed babies, we have to give a high energy density iron fortified formula. Roughly you have to give up to 24 calories per ounce. Basically they need more of calcium, more of phosphorus, more protein and trace elements as we have discussed earlier. and multivitamins are usually unnecessary for them because they are given multivitamins through this formula. And these babies also you can start weaning foods after 6 months, and you have to monitor growth properly. Even overgrowth or undergrowth, both are dangerous. So AAP has clearly, American Academy of Pediatrics has given a clear statement telling that use of preterm discharge formulas up to postnatal age of 9 months will result in greater linear growth, weight gain and bone mineral content compared with use of term infant formulas. Because many of us are always in doubt how long I should continue this preterm formula or post-discharge formula. They have given a statement of up to 9 months you can continue these formulas to achieve proper growth. And postnatal growth you have to monitor in proper charts wherein it will be given. For each gestation age category, postnatal growth curve is to the right of reference curve. So this is the in utero growth curves. Postnatal growth curves is towards the right of the reference curve. And for preterm infant, as we discussed, the composition of the post-discharge formula is intermediate between term and preterm, but there are some differences. Like compared to term formula, the preterm post-discharge formula will contain more protein and contains extra calcium, phosphorus and zinc. Zinc is one nutrient which lot of research evidence has come telling that this is required to promote linear growth, and it may contain some additional vitamins and trace elements. Regarding micronutrient supplementation for preterm babies, there is no need to supplement if they are taking post-discharge formula with all vitamins inside. So post-discharge formula will give more water-soluble vitamin than a term formula. And about fat-soluble vitamins, very little data is there. So post-discharge formula supply enough fat-soluble vitamin. But if somebody is taking only mother's milk, vitamin A, D and E levels are dependent on mother's nutritional status. So for them we need to supplement vitamin A, D and D. So if it is a healthy preterm babies after 3 kg weight, there is no need to supply water soluble vitamins, only with the exception of vitamin D, for which lot of evidence has come now to supplement vitamin D in post-discharge states. So if you are having availability for all resources, this table will tell what to do. Say if a baby is discharged, if baby is on breastfeeding, completely breastfed baby, you need to do only follow up within 48 hours of discharge. You have to come back again, then closely monitor growth, see supplementation, start iron, and you have to do educational counseling and support them on what to do and how to give breastfeeding. And if baby is growing well, then no need to do anything. But if baby is growing not well, then you have to use human milk fortifier or a post-discharge formula, then obtain a help of lactation or dietitian consultant and monitor the breastfeeding technique and continue close follow-up. Whereas if a baby is taking only post-discharge formula, you have to closely monitor growth. And if a baby is growing well, you can continue post-discharge formula till 9 months. If the baby is not gaining weight well, then you have to assess the volume intake and always increase the calories. If baby is not growing well despite post-discharge formula also, then you have to seek why the baby is not growing well and look into causes like infection or cold stress or multiple factors may be there. So this is to summarize how to follow up the babies who are discharged from ICU. Basically, formula fed preterm infants, they are given proper diet in first year of life to replenish the growth and energy deficits which they have acquired in utero and soon postnatal birth in NICU. And those who are breastfed babies also, they need to be monitored very closely and employ individual feeding to get proportional growth. And most optimal strategies for VLBW babies are yet to be defined, and further research is required to determine the best practice guidelines. Everybody has to individualize depending on their own baby, their own patient and mother-infant dyad on how to get proper growth. But what is more important is serial measurement of growth and maintaining post-discharge feeds till that universally accepted protocols are available. By doing all this, by giving proper nutritional support in post-discharge states, we are reducing the morbidity and we are improving the proper neurodevelopmental outcome, and better nutritional support facilities will lead